All right, welcome back to our next high-yield pharmacology review for exam 3. This is Mike Fiore speaking. You'll hear Mina go through the dermatologic agents, the antibiotics, and the hematinic agents a little later. So we'll start off with the autonomic agents. As always, disclaimer, we took the course last year, so we have a good idea as to what will be on the exam and the questions that they're going to ask, but we're not working with the professors. We don't know exactly what they're going to ask, so it's like playing Vegas. We have a good shot. We have good odds at knowing what the questions are going to be, and we're going to give you those answers, but we are not comprehensively covering all of the subjects, so don't forget to read the notes. All right, so we'll start off with the autonomic agents. Honestly, this is probably the most important subject of the entire course. It's extremely highly tested on step 1. It's extremely important as you go forward. Most people will be on an autonomic agent. When most patients you see will be on an agent that we'll cover in the next few slides. So you really gotta know this stuff cold. But if you know your physiology, it sort of makes sense. So, we've talked a lot about the autonomic nervous system. I'm sure you've heard about it before. It's sort of broken down into the parasympathetic and the sympathetic, and then there's that, new third part of the autonomic nervous system, the enteric system, which is just in your GI tract, but, we're not worrying about that. So I believe the way of differentiating, or one of the important ways of differentiating parasympathetic and sympathetic, is the neurotransmitter that's actually used at the nerve terminal. Parasympathetic being acetylcholine and sympathetic being norepinephrine. We've also described it as fight or flight and rest and digest. I apologize, I flipped it. Fight or flight is sympathetic and rest and digest is parasympathetic, and that in a way helps you understand some of the effects of each of those different systems. Epinephrine and norepinephrine being, as I said before, sympathetic, and acetylcholine being sympathetic, and adrenergic and cholinergic is another way of defining the two. So, if we look here on the right, we can see that the cholinergic or parasympathetic nerves have a long presympathetic to the ganglion, and then a short postsynaptic terminal to the effector, muscle, gland, what have you. Whereas with our sympathetic, we know that the presynaptic nerve is actually quite short. The ganglion is right next to our spinal cord, and then we have a long postsympathetic nerve to act on the cardiac tissue, the gland tissue, or what have you. So it's important to remember that, maybe more so for anatomy purposes. And then finally, at the very bottom, we have the somatic nervous system, which also uses acetylcholine and at the neuromuscular junction, which will become important at the end when we start talking about some of the paralytic agents. So you can't really stress this portion enough. You really have to know and understand some of these things. As I said before, for the parasympathetic, we have a long presynaptic nerve, and for our actual, after we get to the ganglion, we have a short postganglionic nerve terminal. And again, parasympathetic uses acetylcholine, and we're acting on muscarinic receptors. So for this specific section, I'm going to focus a little bit more on the parasympathetic autonomic agents. So just, this is something you sort of just have to know. Pretty cold. What we do have some sympathetic. This is sort of the exception to the rule. Sweat glands are actually innervated by acetylcholine on muscarinic receptors. However, it's a sympathetic autonomic activity, not parasympathetic, even though it is acetylcholine and muscarinic receptors. And then, of course, we have the standard sympathetic, which is norepinephrine getting released, activating alpha-1, alpha-2, beta-1. And then there's also some renal activity with dopamine. And then, of course, we have our adrenal medulla, leaching out all of the norepinephrine and epinephrine and working on all the different receptors in the body. And then finally, again, we have our somatic nerve using acetylcholine, but you got to remember it's the neuromuscular junction, and when we talk about that, when we talk about our paralytic agents, because the paralytic agents work on nicotinic receptors, but not the nicotinic receptors in the sympathetic or the parasympathetic. These are nicotinic receptors at the neuromuscular junction. So we have paralysis without any effect on sympathetic or parasympathetic function. So I'm going to talk about some cholinergic neurotransmission, but before I do that, I just want to give you an example of where some of the agents are working. So we have our acetylcholine receptor. That's where we'll have our agonists and our antagonists working. Acetylcholine is released from the nerve terminal. We have Botox, which we'll talk about, which actually inhibits the release of the acetylcholine into the nerve terminal. That's one way of causing paralysis of the muscles. And then again, we also have acetylcholinesterase, which is a way of breaking down acetylcholine, that main neurotransmitter. And by breaking it down, you remove the effect of the cholinergic. You remove the cholinergic effect. However, if you inhibit the cholinesterase inhibitor, you actually will cause an increase of neurotransmission. So it's another way of it's another way of increasing cholinergic transmission. So now we'll talk a little bit more about the specifics of cholinergic neurotransmission. So you got to remember this stuff. This is like probably one of the most important slides. So cholinergic neurotransmission, the effects of acetylcholine. So acetylcholine has widespread effects in the body. On the eye, it can cause pupil contraction. It can decrease the heart rate. It can decrease the contractile strength of the heart, and it will actually slow the heart's It'll slow the heart's electrical conduction. So it'll increase the refractory period between action potentials on the heart. I left question marks next to the blood vessels because I think it's a little bit above what we're going to go through here. So technically, acetylcholine, when it works on the blood vessels, will cause vasodilation, and then it will expand the blood vessels. However, we have acetylcholinesterases in our blood. So there is no direct blood vessel that's innervated by acetylcholine or a cholinergic neuron. So, it will cause vasodilation, but you don't ever see that because you have cholinesterases and there is no cholinergic nerve. So I left it as question marks just so that, it's not really something that you'd be expected to know in this case. It doesn't really have any effects on the blood vessel because it's not innervated by a nerve. In the lungs, acetylcholine causes contraction and mucus secretion. In the GI tract, it increases the motility, it relaxes sphincters, and it causes mucus secretion. And then in the genital urinary tract, it causes contraction of the detrusor muscle, which is the muscle that squeezes your bladder and causes the urine to be expelled. And it also relaxes the sphincters. So, as your detrusor is squeezing out all of the urine, your sphincter will relax, the trigone will relax, and you can pass through. So you really have to know those cold. There are some different things that are helpful to remember. So one of the acronyms is dumbbells. You'll see this probably throughout the next couple of slides. I've just kept pasting it there to hopefully reiterate the point that, so from those effects that I've just given you, cholinergic neurotransmission causes diarrhea, urination, meiosis, pupil contraction, bronchospasms, bradycardia, it slows down the heart. It can cause excitation of skeletal muscles in the CNS. It can cause lacrimation, which is the increase in mucosecretions. secretions. It can cause sweating, and it can cause salivation. You got to know that cold. You have to understand that. So cholinergic neurotransmission, it's your rest and digest. You're resting and you're digesting. So you're pooping, you're peeing, you're breathing, you're making lots of sweat, you're salivating, and it just everything's moving, sort of in a way. So you need to know that cold, because when we talk about muscarinic agonists, things that activate or mimic acetylcholine, these are the effects that you're going to have. And then when we talk about muscarinic antagonists, we'll have the opposite. So, muscarinic agonists. So there are a few. Very lucky in pharmacy school, I think Mina and I I think there were about 10 muscarinic agonists that we had to memorize and maybe 20 to 30 muscarinic antagonists. So you guys don't have to remember as many, but it's, it's still very tough. So we have bethanechol, pilocarpine, carbachol, and then there's this other one that's included, carbamylcholine, and then methylcholine. So these are all agonists of the muscarinic receptors. So I'm just going to jump to the side effects. If they're agonizing the muscarinic receptors, these are the sort of side effects and uses that you're going to get, the ones that we just talked about. So sometimes we say a side effect or a use because, maybe that's what we want. So for example, they're used for postoperative ileus or urinary retention. So we have somebody who is just in an operation and they're not pooping, they're not passing gas. So we give them a possible bethanechol to get them to have GIT movement. It could be a side effect. You could get diarrhea. It's not what you want. Maybe if you're taking it for, Sjogren's syndrome, pilocarpine, to cause lacrimation and salivation, but you could get diarrhea as a side effect of that medication. So some of the effects are what we want depending on the use that we're using it for. So bethanechol, as I said, is postoperative ileus and urinary retention. Carbachol and pilocarpine are sometimes used for ophthalmic uses and can help with open-angle glaucoma. And then pilocarpine is also used for Sjogren's syndrome. And then another high yield is they love to talk about methanolcholine is an asthma challenge test. So what we'll do is we'll have a patient come to the pulmonary function clinic. They'll sit down, they'll do the pulmonary function test, they'll measure their FEV1, they'll measure their FEV1, FEV ratio, and then they'll administer methylcholine, which causes bronchospasms. And then somebody with asthma is actually going to be more susceptible to having worse bronchospasms by methylcholine. So that's very high yield. They love to ask about which drug is used to help diagnose asthma and what does it do. So remember, muscarinic antagonists are cholinergic side effects, or in this case, uses, can help us determine what these drugs are used for and what will happen if you take them. So now we move on to the antagonists. So atropine is our parent muscarinic antagonist. We also have a few more: scopolamine, ipratropium, and tiotropium, and then darafenicin. So as I said, these are antagonists at the nerve terminal. So their effects are going to be anti-cholinergic. So we just talked about all of the side effects or the effects of cholinergic neurotransmission. So they're going to be the opposite of all of these. So you're going to get pupil dilation. Now I always struggle between miosis and mydriasis, the technical terms. Dilation, mydriasis, there's a D in there. I don't know. It's going to decrease your GIT secretions. It's going to decrease acid secretions. It's going to decrease your GIT motility, and it's going to decrease your urinary urgency. So all of these things, it's going to be the opposite of what we had for cholinergic. So that's why if you sort of can memorize or figure out a way to remember what happens when you have acetylcholine, if you remember one of them, you'll always know the other. So they're not, I apologize. They're not used, so for specifically atropine, it can be used for bradycardia, and it can be used to cause mydriasis. It used to be used a lot for people coming in with bradycardia, or if they were in some sort of bradyarrhythmia, you can give that to them and hope that you'd increase their heart rate. Scopolamine is actually the main ingredient in some of the patches that you'll see for people who have motion sickness or seasickness. It's you put the patch on behind your ear to help you for motion sickness. It will cross the blood-brain barrier, and that's why it's used in this specific case. Ipratropium and tiotropium are both agents that are used for asthma and COPD. They're inhaled agents, and they can actually, if we know acetylcholine causes bronchospasms, we give an anti-acetylcholine agent, a muscarinic antagonist, to counter the muscle spasm effect. They're more often used for COPD, but they can be used for both COPD and asthma, and especially in the acute exacerbation of both of those. Darafenicin, another muscarinic antagonist. So this can be used for BPH and urge incontinence, but it's more often used for urge incontinence. Patients who, for whatever reason, are struggling to get to the bathroom and not have a little bit of their urine leak out before they get there because of the overactive detrusor muscle. Now, side effects. Side effects are the opposite of our cholinergic side effects, anti-cholinergic side effects. So decreased sweating, so increased body temperature, dry mouth, constipation, very high yield. Anti-cholinergic drugs are very likely to cause disorientation and confusion in the elderly. So we try to avoid using these drugs in elderly patients. So in addition to mydriasis, it can also cause cycloplegia, which is the inability to accommodate, which is the focusing or the constriction of your pupil when you're focusing on an object as it comes towards you. It can also cause acute ankle closure glaucoma and urinary retention in patients with BPH or just elderly patients in general. So it's very important to remember all of those side effects. And so for people who have overdosed or taken too much of an antimuscarinic drug or an anticholinergic drug, they have a bit of a toxidrome, sort of a saying that you can help you memorize. Hot as a hare, dry as a bone, red as a beet, blind as a bat, and mad as a hatter. Hot being the decreased sweating, dry, again, being the decreased sweating, red, decreased sweating, blind, you're not able to open, your pupils are dilated so you can't really see, and then the mad as a hatter is the orientation. And I apologize, the dry as a bone would more so for the dry mouth and the dry mouth and the inability to secrete any fluids. So that's one that's sort of helpful for remembering some of the side effects of the antimuscarinics. And then we talked about it before. This is in a previous lecture, anticholinergic side effects. Just, another way to try to remember it. I'm not going to go over it again. I talked about it in a lecture, but I'm just bringing it back to just, the sort of the anticholinergic is the same as sympathetic because you're inhibiting the cholinergic system, so you only have the sympathetic system. So it all sort of makes sense physiologically. So we'll finish up this section just talking a little bit about the neuromuscular agents. So as I was saying before, you have the acetylcholinesterase enzyme in the nerve terminal, which can break down acetylcholine and reduce its transmission. But we've found that we can block the acetylcholinesterase and have some effects that are able to get around the problem of giving a muscarinic agonist. Sometimes giving the agonist just, they haven't found a way to, as we'll talk about in the future with beta 1, beta 2, alpha 1, alpha 2, they haven't really been able to isolate the different muscarinic receptors in the same way. Some drugs can, but there's a lot of crossover between M1, M2, and M3. So we've figured out that by inhibiting the acetylcholinesterase, we can sort of have another way of increasing cholinergic acetylcholine transmission and having some new effects. So we have a few acetylcholinesterase inhibitors: neostigmine, physostigmine, pyridostigmine, and edrophonium. So obviously these are inhibiting acetylcholinesterase and they're increasing the amount of acetylcholine in the nerve terminal. So very high yield. You need to know edrophonium is the diagnostic test that you would use for myasthenia gravis. This is going to increase the amount of acetylcholine that is going in the nerve terminal. So these patients who have antibodies that are blocking the blocking the muscarinic receptors, you're going to be able to overcome this. And if somebody's in an acute myasthenic, having an acute myasthenic event, they're going to improve for a short period of time. So even though we know now, and I'm sure as you guys know now, having taken immunology, we can actually just look and try to see if the patient has anti-acetylcholine antibodies. They still love to ask this question, and you need to know that edrophonium is how you sort of diagnose it pharmacologically. You can use them for ileus and urinary retention, as we talked about before with some of the other muscarinic agonists. I actually had a patient when I was in pharmacy school who had Oligo-V syndrome, or Ogilvie syndrome, which is like a massive megacolon. I think his colon was dilated to something like 7 centimeters, and we gave him neostigmine to get him going, and it worked. And then finally, for anti-cholinergic overdose, you can use physostigmine, because you're actually overcoming the inhibition of muscarinic antagonist by inhibiting the breakdown of the acetylcholine in the nerve terminal, and you're giving more and more and more. So those are the traditional anti-cholinesterase inhibitors that you'll see used. We also have a few newer agents, donepezil, galantamine, rivastigmine, and tacrin, that, same mechanism of action, but these are all used for Alzheimer's disease. So you just want to associate these for specifically donepezil. Donepezil is the one you'll see the most. It's same mechanism, but it's only used for Alzheimer's disease. And again, same slide, same information. These are going to have cholinergic side effects. Remember dumbbells, diarrhea, urination, meiosis, bronchospasm, bradycardia, lacrimation, sweating, and saliva. So as I said before, sometimes this is the effect that we're trying to get. So urination and diarrhea, when we use neostigmine and ileus and urinary retention, that's what we're using it for. Just remember that that is sort of its use and its side effect. But we wouldn't want that patient to then start having bronchospasms if they had asthma or such. So, just remember these are the side effects. Sometimes it's a use, sometimes it's a side effect. And finally, just to touch on some of the irreversible agents. So all of these agents will bind to the acetylcholinesterase inhibitor. After their half-life and they're metabolized, the agent will, be destroyed and will leave. We have some irreversible acetylcholinesterase inhibitors, and these are what we call suicide substrates. They will bind to the they will bind to the acetylcholinesterase inhibitor, and they will in effect destroy the enzyme, and so we'll lose the enzyme, and depending on how long it takes the body to go through transcription, translation, and create another one, we won't have them in our body. And so these actually are used in some nerve gases in some of the terrorist attacks that you've seen on TV, and then they're also used as toxins to kill bugs. So RAID, I believe, is one of them. You'll use this to or if you're just going to get your house fumigated for termites or something like that, they'll use irreversible acetylcholinesterase inhibitors. So just remembering that the nerve gases and ecothiopate are sort of bug killers, and unfortunately in some terrorist attacks. But you can now know that when you see some of those videos, the people that they're suffering, they're salivating, they're having bronchospasms, and this is sort of what's going on with them when those things do occur. Finally, some neuromuscular blockers. So these are the drugs that you're primarily going to see maybe in the ICU or the operating room when it's time to paralyze our patients for good reasons. So these aren't acting on the autonomic nervous system, these are acting on the somatic nervous system. Right now we're acting on the neuromuscular junction of your skeletal muscles. These competitively block the nicotinic receptors in the neuromuscular junction. Very important to remember that. We're not acting on the nicotinic receptors that are the ganglionic in our para and sympathetic nervous system. This is only in the somatic nervous system. And these are, used for muscle paralysis, for intubation, and for surgery, because, you wouldn't want your patient to bite down on the ET tube as you're trying to intubate, and you wouldn't want them flinching when you're trying to cut into them to take out the appendix. So we have a few non-depolarizing, so these just inhibit the nicotinic receptors without causing depolarization of the nerve downstream. We have tubocurine, atracurium, cisatracurium, mivacurium, rocuronium, and vecuronium. You'll probably hear about roc and vec the most when you go out into your clerkships. And then extremely important point, maybe not so much for the boards, but just for clinical practice. If you're ever going to give somebody a paralytic, please sedate them before you paralyze them. Would you want to be in a hospital room bed and paralyzed, unable to move any muscle before you're sedated? It would be a horrible experience. So always administer your sedative before you paralyze. And then finally, a very high yield agent, which is a depolarizing neuromuscular blocker. So we have these two different types, the non-depolarizing and the depolarizing. And the name sort of gives a clue as to how it works. So succinylcholine is a strong acetylcholine receptor agonist, and it produces sustained depolarization. So when you administer acetylcholine to someone, you'll actually see their muscles start twitching. That's called fasciculations. So you administer acetylcholine, watch their legs and their arms to see, you'll see the muscle fibers start twitching. And so it's a little counterintuitive. You're giving an acetylcholine receptor to activate the nicotinic receptors on the neuromuscular junction, but then it produces a paralysis. Well, the theory is it produces such a strong depolarization that the nicotinic receptors are actually desensitized afterwards. So it's broken down into two phases. Phase 1, you have your prolonged depolarization. You give your succinylcholine, you see the fasciculations. But then on phase 2, you have a block to repolarization. The acetylcholine receptors are available. Your succinylcholine has been removed from the receptor, but they've become desensitized and they cannot be activated. Very important side effect: cause hypercalcemia, can cause hyperkalemia, and it can cause malignant hyperthermia. I think it's 1 to 2% of the population has this reaction where it's a cascading reaction. You give succinylcholine, and you just start having such rapid muscle twitching and calcium release as your muscles are contracting that you go into this malignant hyperthermia. The treatment for this is dantrolene, extremely high yield. You need to remember succinylcholine causes malignant hyperthermia. Malignant hyperthermia can be treated with dantrolene, which inhibits the calcium release from the sarcoplasmic reticulum, which we know is the part of the mechanism of how muscles contract. Finally, we just have our acetylcholinesterase reactivator. For whatever reason, we give a little too much of our non-depolarizing agent. We can use 2-PAM, 2-paralidoxamine, which can reactivate our acetylcholinesterase. So just the high yield point about that is just remembering that 2-PAM is our sort of, overdose of neuromuscular blocker. It is our way of bringing that back. Finally, we have Botox. So as you can see on the chart on the right, Botox inhibits our release of acetylcholine into the nerve terminal. It is used locally to treat dystonias, achalasia, which, as you'll learn, is sort of this inability of the esophagus to relax. You can see it on x-ray. I believe it's called a bird's beak sign, and to stop muscle spasms. It's also used for migraines, and it can also be used for the cosmetic reduction of facial wrinkles, which I'm sure we're all aware of. Botox, removing wrinkles. Some side effects: it can cause a little local redness and pain on the injection site. And obviously, if we are giving a paralytic agent, it can cause some muscle weakness.